All right, let's jump straight into this explainer. Today, we're stepping onto the surgical ward, specifically into the high-stakes, hyper-dense world of surgical critical care. We're going to break down the choice architecture you absolutely need to navigate those strict physiological details, because out there, subtle variables dictate massive clinical shifts. We're looking at the exact mechanical, infectious, and temporal boundaries where just one delayed decision, well, it can literally be fatal.
So picture this scenario. You've got a patient presenting with acute abdominal distension, 103-degree fever, escalating jaundice, and a mean arterial pressure that is dropping fast. What's your move? Do you cut, do you scope, or do you wait? This exact situation forces you to recognize the granular variables that shift a patient from conservative management right into an emergency intervention. Your mastery here, your ability to synthesize these data points on the fly, is the actual difference between life and death.
Okay, let's start with Module 1, Bowel Obstruction Mechanics. Specifically, we're looking at mechanical obstruction versus adynamic ileus.
We've got to establish the baseline pathophysiology of the obstructed gut, and that means setting strict mechanical boundaries. On one side, we have a true small bowel obstruction, or SBO. This is a physical blockage, usually from post-surgical adhesions or hernias. If you look at a CT scan, you'll see dilated bowel loops hitting a hard, definitive transition point. But on the other side, adynamic ileus. This is a functional loss of peristalsis, maybe post-op, maybe from hypokalemia. And ileus gives you diffuse gas dilating both the small and large bowel. Zero transition point. None.
Now, if you have a stable mechanical obstruction, it buys you a little time. The protocol is strict. Make the patient NPO, drop an NG tube for decompression, and blast them with aggressive IV fluids to fix those electrolytes. But, and this is a huge but, you have to constantly monitor for the physiological triggers that force an immediate pivot. You are watching like a hawk for the strangulation red line.
And here is that red line. We call it the absolute surgical trigger. If your conservatively managed SBO patient suddenly spikes a fever, or you see leukocytosis, tachycardia, or localized peritonitis, strangulation and ischemia are underway, period. The choice architecture here leaves no room for debate. You immediately bypass that NG suctioning and go straight to an emergency exploratory laparotomy. If you don't, you're looking at complete bowel necrosis.
Moving from mechanical plumbing over to infectious cascades, Module 2, biliary tree malfunctions, tracking the dynamics from cholecystitis to cholangitis. The gallbladder and bile ducts are basically a highly pressurized system where an obstruction breeds severe infection fast. A simple case of cholelithiasis, the gallstone is just resting there, throwing clear posterior acoustic shadowing. The patient might have some upper right quadrant pain after eating, but they're stable. But when that stone occludes the cystic duct, acute cholecystitis sets in. Suddenly, you're dealing with a really thickened gallbladder wall and a halo of paracholecystic fluid. Palpate that upper right quadrant and you'll get a positive Murphy sign, an inspiratory arrest. They need targeted intervention.
It's actually wild to map how rapidly a patient decompensates when a stone blocks the common bile duct instead of just the cystic duct. It kicks off as cholelithiasis. The patient is jaundiced, afebrile, with elevated alk phos and bilirubin. But that biliary stasis? It's an open invitation for enteric bacteria. This escalates at breakneck speed into ascending cholangitis, and if you miss it, into highly toxic suppurative cholangitis, bringing shock and altered mental status straight into the picture.
Which brings us right to the decompression red line. If your patient hits Charcot's triad, fever, right upper quadrant pain, and jaundice, they have acute cholangitis, period. If they cross over into Reynolds pentad, meaning they now also have hypotension and an altered mental status, they are actively decompensating. The mortality rate here is terrifying, so you have to initiate an aggressive execution sequence right then and there.
And you have to sequence this perfectly. Step 1, immediate aggressive IV fluid resuscitation to stabilize those hemodynamics. Step 2, get broad-spectrum IV antibiotics on board to fight off the systemic bacteria. Step 3, immediate biliary decompression via ERCP. You literally have to go in endoscopically and clear the pus and the stone out of that common bile duct. This leads us to a non-negotiable rule, the ERCP imperative. Never, ever delay an ERCP because you're waiting for an elective cholecystectomy slot. In a toxic patient with Reynolds pentad, the choice architecture forces urgent endoscopic decompression. Taking the gallbladder out is definitive, sure, but that happens later when they aren't in septic shock. The ERCP is what keeps them out of the morgue today. All right, let's shift gears to Module 3, postoperative fever, and what we call the temporal calendar matrix.
Managing a post-op fever is basically chronological deduction. It follows a relentless timeline mapped to the 5 Ws. Days 1 to 2 is wind. Think atelectasis or early pneumonia. Days 3 to 5 is water, usually a UTI from an indwelling Foley catheter. Days 5 to 7 is walking, where you're hunting for a DVT or a pulmonary embolism. And days 7 to 10 is wound, pointing right at a surgical site infection or a deep abscess.
So, mapping the symptom to the correct day absolutely dictates your intervention. For instance, if you have a patient who spikes a 101.5 fever on post-op day 8 after an open colectomy, and that incision is erythematous and indurated, the choice architecture forces you to open that wound and pack it. You don't just hand them an incentive spirometer for a day 8 fever. You attack the wound timeline directly.
Now there's a singular low-frequency variable here, the 5th W, wonder fevers. These totally break the standard chronological rules. The scariest example is malignant hyperthermia. This presents directly after giving anesthetics like halothane or succinylcholine. You'll see severe rigidity, massive temperature spikes, and metabolic acidosis. It requires immediate recognition, active cooling, and dantrolene. You completely ignore the standard calendar.
Finally, we hit Module 4, clinical reconciliation and disruptive surgical traps. Let's talk about high-stakes error mitigation.
We need to isolate those complex decision boundaries where the wrong choice leads to a fatal trap. Error mitigation is all about spotting redundancy and mistimed interventions. For example, ordering a HIDA scan when an ultrasound already confirmed acute cholecystitis, you're just wasting critical physiological windows. Or doing an immediate laparotomy for a simple adynamic ileus instead of resting the bowel, you're actively harming the patient. And delaying an ERCP in toxic cholangitis, like we just talked about, is a complete failure of prioritization.
Here's another massive trap. Imagine a patient rolls in with an incarcerated or strangulated hernia. Extreme pain, reactive erythema, fever, it's totally irreducible. Trying to manually reduce that hernia while pumping the patient full of hydromorphone is catastrophic. Strangulated bowel is necrotic bowel. That mandates immediate definitive surgical exploration, no exceptions.
So, what exactly do you do when the whole system crashes at once? Think back to our integrative scenario, an acute post-op patient showing concurrent rapid abdominal distension, temperature spikes, escalating jaundice, and a falling MAP. When mechanical, infectious, and temporal failures all hit simultaneously, you have to sequence your priorities flawlessly. Establish fluid volume targets instantly, secure broad biliary drainage, and do targeted wound inspections based on their exact post-op day. It's a step-by-step physiological puzzle.
And listen, there is a profound legal and ethical boundary tied into all of this, the EMTALA violation trap. If you're the on-call surgeon, you have to physically lay eyes on a deteriorating patient. Doing a phone consult for a patient in extremis or telling an ER doc to just push some morphine and try to reduce a strangulated hernia, that's a total collapse of clinical responsibility. Under EMTALA, failing to evaluate that acute surgical abdomen in person is a huge deviation from the standard of care. It's straight-up negligence.
So master these strict physiological details, know your CT transition points, memorize that 5 Ws calendar, and respect the sheer speed of ascending cholangitis. Because out there on the floor, when that mean arterial pressure crashes and those red lines are crossed, your real-time synthesis of these subtle variables is literally the only thing standing between your patient and the morgue. Will your choice architecture save them, or will you fall into the trap? The clinical matrix doesn't forgive mistakes. That's your big takeaway for this explainer. Stay sharp out there, and I'll catch you next time.